like to introduce you to Dr. Farah Alahi, who's our speaker tonight, from the Leader of Digital Ethics and Transformation at Surrey and Borders Partnership NHS Foundation Trust. Now, it's a good mouthful, isn't it, Farah? So without further ado, what I'll do is I'll duck out and hand over to you, Farah, and you share your slides and off you go. Thank you. Off you go.
Great, thank you. I'm just going to go ahead and share my slides from the beginning. So bear with me. Yes, that should work. Perfect. So first of all, thank you so much to those that have attended and taking your time out of your evening to listen to this webinar. So as it's been introduced, this is the Advancing the NHS, the role of digital ethics in delivering effective care webinar. So I'm going to just show a contents page here, which provides a bit of information about what I'd like to talk about today. So I'll go through a bit of an introduction to myself. I'll then talk about digital ethics, what it is, what it means, what the definition is, how does it tie into the national picture, why is it important? And then I'll do a bit of an introduction to the team that I work in at Surrey and Borders Partnership NHS Foundation Trust. Then I'll talk about how we ensure we get ethics embedded into the organisation. I'll use some case studies to bring the work to life, and then I'll follow with some next steps, and then opportunity for some questions. So a bit of an introduction about me. My name is Dr. Farah Alahi. As has already been said, I'm the lead of digital ethics and transformation at Surrey and Borders Partnership NHS Foundation Trust. This is a mental health and community trust, and we cover Surrey and areas of Hampshire as well. To my knowledge, my colleagues and I were the only dedicated digital ethics professionals in the NHS, so very much at the forefront of this work. My background is a mixture of academia and research and working in the NHS in various digital transformation and programme project management roles. My interest in digital health came from my PhD, which was officially titled Health Sciences, but my thesis focused on digital mental health, particularly virtual reality therapies. I'm also currently on cohort 6 of the Digital Health Leadership Programme, which is a flagship digital leadership programme delivered by NHS England and Imperial College London. So what is digital ethics? I think if you searched for this online, you'd find different types of definitions, similar definitions, but different types. And I think when my colleagues and I were thinking about the definition that we wanted to use, we did our research and we came up with the following, which is officially on our trust website. So for us, digital ethics focuses on the responsible use of data and technology within an organisation. It extends beyond those legal boundaries to embed moral and conscious decision-making. And the aim is to minimize risk and ensure optimal benefit to the individual served by our organisation. So our service users and our staff and other stakeholders as well. For us, our trust is committed to investing in innovative practice that supports and improves quality of care. And this extends to the use of data and technology. However, due diligence is essential to ensure that digital solutions are ethical so that they don't compromise the autonomy, safety, security, accessibility, and privacy of our service users. And I think one of the key things when it comes to ethics is that this isn't just about legality and legal aspects in our legislation. This goes beyond that. And quite often there can be a confusion about both. It does overlap, but this isn't about just following legislation. This goes one step further. So what is the national picture? Why is digital ethics important? It sounds important, but why is it important? So as you can imagine, and as I'm sure all of you are experts in your field, there has been this interest, of course, in digital technology, how it can transform not only healthcare, but our education, the way that we work, for example. And with that interest and that development of digital innovation in various aspects of our life, we see this interest in how do we make this ethical? How do we ensure that we are empowering citizens, we are empowering people within organizations to understand the digital technology that they are using. So I've just picked out 3 examples here. I'd love to talk about all of the policy reports and briefing papers, but we unfortunately don't have the time. But I wanted to pick up 3 elements here: the digital charter, the Centre for Data Ethics and Innovation, and the Digital Ethics Charter. So a few years ago, the government, or the Department for Science, Innovation and Technology, actually developed something called the Digital Charter. I think it was published in 2018 or 19, around that time. So quite a long time ago, pre-pandemic. And it was all about ensuring that the citizens, businesses, and society as a whole understood the digital technology that was being used in their organizations, in their society, that there were some norms and rules for the online world, and that this charter would help put that into practice. So very much very innovative back in 2018-19. Subsequently, the Centre for Data Ethics and Innovation was developed by the Department for Science, Innovation and Technology. And as some of you already know, the CDEI leads the government's work to enable trustworthy, and I really like that word because that's very much ethics, trustworthy innovation using data and AI as part of the Department for Science, Innovation and Technology. And then finally, the Digital Ethics Charter. This is an independent organization that's created this, and this is a charter that organizations can sign up to, their principles of implementing those digital ethics into their organization. So I think you can be any organization. You don't have to be in healthcare or in local government. You can be in the private sector. So it's all about how you can think ethically, build ethics, explain ethics, and share ethics within your organization. So these are just three core elements that represent kind of the national picture of how important digital ethics is, digital and data ethics. But more specifically in healthcare, again, really similar in healthcare, we have seen lots of briefing papers and policy reports and strategies developed within maybe the last sort of 5 to 7 years. I think, the NHS long-term plan, which was published in 2019, spoke about how digital innovation, digital transformation can transform the NHS to improve care, improve the workforce, improve targets, lots and lots of things. Very much, there is a really great opportunity here. Of course, not without some challenges. And I've just picked out a report published in 2021 by NHS England about what good looks like, the 7 success measures for successful digital transformation. And that's illustrated on the left-hand side. And what I really like about this sort of graph is that you can see where digitize is, you can see safe practice, ensuring smart foundations, well-led, and in the middle there is empowering citizens. And I think that's really, really key with any digital transformation work that anyone does. And this report was very much targeting NHS leaders, and it very much fed into other subsequent policy reports that were published, such as the Plan for Digital Health and Social Care to accelerate digital and data transformation. So again, digital ethics, digital transformation, it's been a really key part in not only healthcare, but overall in the national picture within the last sort of 5 to 10 years. Again, another couple of examples here. So on the left-hand side, we have a report that was published by NHS Digital on their privacy, transparency and ethics work that they did in 2021. I picked this out because this is actually specifically about ethics, digital ethics. NHS Digital does not exist anymore. It was actually merged with Health Education England into NHS England overall. So there was a big merger. Some of you may know, I think a couple of years ago. And on the right-hand side, we see a snapshot of the NHS England Transformation Directorate. So they've got an AI ethics initiative here. And I would encourage those of you that are interested to visit the website, because they have lots of, again, reports and training kind of courses there about AI ethics. And I think, as some of you probably know, there's been a lot more interest in AI over the last few years. There's been an interest in AI ethics. So I think we see a lot of ethics work done within AI. How do we ensure that AI is ethical, safe, secure for all of us? And of course, we all see how AI is discussed in the media. It's constantly in the news. And we see this not only in the NHS, this interest, but actually in the private sector as well. There are lots of white paper reports and interests there. And also in local government, for example, and national government. But for us, ethics isn't just about AI. AI is part of digital technology. It's not a standalone element for us, the way we work and operate. So I've hopefully given you a bit of a national picture, and hopefully that's been of interest and a definition of digital ethics. What I want to do is just focus into the work that we do as a team, and I'm going to introduce the team that I work in, which is the Digital Ethics and Assurance team. We were founded, or we were organised a couple of years ago, I believe, and we were organised within the Digital Directorate in our trust. As a way of answering that question of how do we ensure that our digital infrastructure and transformation programs are meeting the highest of ethical and assurance standards. So our trust has actually got a really good reputation when it comes to digital transformation. We've got a very big digital directorate. We're at the forefront of innovation, which is very, I think, unique for a mental health trust. So we do some fantastic work, I have to say. So I think it's quite fitting that the Digital Ethics and Assurance team was founded within our trust. Some of my colleagues that I work with, Rafia Ansari and Dr. Emilios Lemoniatis, who were the Chief Digital Ethics and Assurance Officers. This is a quote from them, that at Surrey and Borders, we are taking a lead to embed ethical thinking and practice across our digital teams. And here I've got four sort of elements or kind of underpinning kind of core aspects of which we abide by. So our safety, privacy, security, and accessibility are really, really important to the work that we do. And our mission is a unified, accessible, efficient, and coherent framework for digital best practice. We define and deliver a strategic best practice approach to digital assurance with a focus on ethics. And this ensures that the technology we provide facilitates the best possible outcomes in health and care. And that we create an awareness and these processes to make ethics actionable and practical, whilst ensuring the trust meets its legal and statutory obligations. And on the left-hand side, there's this quite famous image of the pillar of care ethics. And here there's empathy, responsibility, competence, and trust. And for us, these aren't just words, these are actually really core components of the work that we do. And what I like about this illustration is at the bottom, we've got these three kind of foundations there of data and technology, practices and organization, and behavior and communication. For us, you know, one steps on top of the other, one is feeds into the other. That behavior change, the organizational culture, that is key to digital transformation. That is a huge part of the work that we do. It's not just about taking a definition of ethics and just sharing that with our colleagues. It's really about change management here. How do we make this not just something of an add-on, but actually really embedded in our organization? This is just a sort of a graph of the team structure. So we oversee three areas of three sub-teams, essentially, three core areas in healthcare. So electronic health records management, digital clinical safety, and information governance. And our data protection officer is within the information governance team. And this is actually quite a unique setup, because when we talk to other organizations that do digital data ethics work, quite often the data protection officer doesn't work so closely with those individuals that are doing digital ethics work or data ethics work, just because of structures. But we are very fortunate. We have our data protection officer and our other colleagues in our team providing really important legislative work within the NHS. So we can really work closely together. And as I've said before, we sit under the Digital Directorate in our trust. For those of you that might not know, because I appreciate not everybody is from a healthcare background who is attending this webinar, I'll just provide those definitions of what those areas are. So some of you may have not heard of clinical safety or digital clinical safety. For us, the law requires for software to be clinically safe, leading to a reduction in harm to patients using the software. So potential hazards need to be identified within a software, and suitable mitigations need to be provided as a result. With electronic health records management, I think most of you probably do know that this is a process by which an organization manages all the aspects of records, whether internally or externally generated, and in any format or media type, from their creation all the way through their life cycle to their eventual disposal. And then finally, information governance, which is a framework for handling personal information in a confidential and secure manner using appropriate ethical and quality standards in the health service. So it provides a consistent way for employees to deal with many different information handling requirements. So how do we actually ensure digital ethics is embedded into our organization? How do we actually do the work? So for us, one of the key things was making sure we didn't reinvent the wheel. This is a huge piece of work that we do, and no sort of technology is off limits essentially when it comes to digital ethics. So how do we actually, without reinventing the wheel, actually are as effective as possible with the work that we do? So we did some scoping and did some research, and through our own expertise, and what we decided to use as our main framework was something called the digital technology assessment criteria. So for those of you that aren't in digital tech or innovation, you may not have heard of this. For those of you that are, you probably know this very well. Many suppliers do know of this framework. And what I will do, instead of talking about it here, I'll play a video which actually explains it in a little bit more detail.
Is your new digital health technology DTAC ready? The Digital Technology Assessment Criteria for Health and Social Care, or the DTAC for short, is a set of criteria for organisations to use when introducing new digital health technology. Using it will give staff, patients and citizens confidence that the digital technology they use meets our national minimum standards on clinical safety, data protection, technical security, interoperability, usability and accessibility. The DTAC brings together legislation and best practice from across the health and social care ecosystem into one place, so assessing products is simple, quick and consistent. So, who does what? NHS and social care organisations should assess any new digital health technology products against the DTAC as part of each new procurement process or contract renewal, including staff or patient-facing apps, systems and web portals. Tech developers can use the DTAC to make sure their products meet our standards and prepare for assessment. These assessments will be carried out by local health and social care organisations. Make sure your digital health technology is DTAC ready. Find out more at www.nhsx.nhs.uk/DTAC.
Great.
Is your new...
Let me just go on to the next slide. Sorry about that. So hopefully that gave a bit of an introduction to DTAC, and it is a very clear and concise form that is to be completed by the supplier first. They are required to complete the DTAC form, which is available on the NHS England website, before they are ideally procured by the NHS organisation trust, or when their contract is going to be renewed. My team, my colleagues and I, we do our independent assessment as well. And we then compare to see if there are any differences, whether we need to improve certain aspects as well. And what I like about the DTAC is that it covers clinical safety and information governance and cybersecurity, which of course, as I've discussed, we work with our colleagues in our team, and that is our legislative requirement. But it covers usability and accessibility, which I do think are areas that need a lot more work. Currently, a lot of accessibility and usability work is not considered, it's not always at the forefront, it's sometimes left behind. And I think when it comes to digital technology, we want to make sure we are not increasing the gap, increasing that digital divide, or creating that digital exclusion. We want to make sure that we are reducing that gap. So I think this is a great way and an easy way, without reinventing the wheel, to assess a technology. So that is our main framework that we use in our day-to-day work, in our day-to-day projects. But what other tools do we also use, depending on the kind of work that we're doing or the projects that we're doing? I've got the Data Ethics Canvas here, and this is created by the Open Data Institute, the ODI, published in 2021. And I've got a snapshot here, but I would encourage you to go to the ODI website where they actually have an interactive canvas that you can actually complete and look at. And here you can actually, it's very interactive actually, and it's very useful in a virtual workshop or a face-to-face workshop to have this canvas and actually complete it with your stakeholders, whoever that might be, and really identify where some of the key challenges are, where are the aspects of the piece of work that is going well. So really a great way of mapping some of the core components of a project. So for example, one of the boxes here says, what is the ethical and legislative context? What are the rights around data sources? What are sharing data with others or limitation in data sources? So it's very, very open, very, very helpful and a great collaborative tool. So I would recommend using this. The other framework that we have also used and you can use is the data ethics framework, which was published by the Central Digital and Data Office in 2020 as part of the UK government. And again, very much a framework where you can complete this sort of form, these sorts of boxes, and tick off certain aspects to check how transparent, accountable and fair the technology is. And it goes into a bit more detail in the form on the website. So again, I would encourage you to take a look at it if you are interested in this framework, but we have used it in some of our projects as well. And then finally, our equality impact assessment, which is actually very important, as I've spoken about accessibility and inclusion, making sure that the technology we're implementing into the trust, or we're helping to implement into the trust, is actually meeting these legislative requirement. It's actually not discriminating against any groups of any protected characteristics. That's really, really key, and we ensure that the EIA is completed as well. And the responsibility of who completes what might be different. So for the EIA, for example, we feel it's preferable for our clinical colleagues to complete it, whilst for the DTAC, it's completed by a supplier. So this is very much about us facilitating and ensuring the paperwork and the frameworks are completed by the right stakeholders, so to speak. Speaking of stakeholders, our key stakeholders, many of them, but I've picked out a few here, is our digital procurement colleagues. So of course, the procurement team are responsible for purchasing, procuring, renewing contracts. So we work closely with them. We want to make sure that the DTAC is completed before anything is procured, for example. Our research and development colleagues. So if there's a research project taking place, that's a digital research project. And we have been alerted to some ethical issues in relation to the digital product, then we will work with them. Our legal colleagues, of course, if this falls into a bit more of a legislative issue, then we would work with our legal colleagues in the trust. Our clinical services, which actually is one of the most important stakeholders, as you can imagine. These are our clinical colleagues who are on the ground using the digital technology. So they will know firsthand whether there are any actual issues when they're actually using it, not only for themselves, but for the service users as well. So it's really, really important that we develop a good relationship with our clinical services, and we know when to step in, but also step out again as well. Our operational colleagues are very, very important, and our communication colleagues too. So going back to one of the slides at the beginning when I was talking about our team, and I had that, pillar of care ethics, and I talked about change management. Engagement is really, really important, and our communication colleagues help us to engage effectively with our colleagues. We also have our ethics and assurance review group, which is an opportunity for us internally, our core digital ethics and assurance team, to come together and talk about our various projects that we have. And sometimes we have our key stakeholders attend these meetings as well to talk about a particular project. So it's a great opportunity to capture where we are with a particular project, what involvement we need to have. With ethics, what we don't want is for us as a team to be involved when something has gone wrong. And then people are thinking about, oh, who can help with this? Okay, we're going to go to the ethics and assurance team. We want to make sure that we're stepping in at the right time and dealing with the issues there and then. And that we also can facilitate, going back to that word facilitation, we can scope and see actually who is the best colleague within the trust that we can pull in to actually help with this issue as soon as possible. Who are our partners? I've got one example here, a bit of a plug on our stakeholder engagement, or our partnership with the Open Data Institute, who's been working closely with us for over a year now to help embed ethical thinking and in a practice across our trust, our digital teams. And please keep an eye out on their website for any further updates. But that's been obviously fantastic working with the ODI so far in our ethical thinking work. I've spoken a lot about, of course, digital ethics and how we conduct this digital ethic work and embed ethics into the organization, but I wanted to bring it to life with some case studies. I've kept names out of the case studies, of course, for confidentiality purposes, but hopefully it will be quite clear. So an example of a case we recently worked on was there was a clinical service at SABP, which is our Surrey and Borders Trust, and our service was due to renew a contract in late 2022 with a supplier that provides an AI self-referral tool. This AI tool is well used, it's well liked by the service, well liked by the service users, the clinicians, and we're going into this process where there needs to be a renewal. But we were asked to step in to conduct a review of the supplier's tool to ensure that they were meeting the trust assurance and best practice standards. This piece of work took about 6 months. Again, in the NHS, there's so much business as usual work. It's sometimes things can take a little bit longer than anticipated, which is hence the timing of the 6-month piece of work. But it took 6 months, and how we tackled this was we first of all checked that the DTAC was completed. If not, we asked them to do it, and we asked them to complete it again. We asked them to complete a clinical safety assessment. There are some forms that need to be completed by the supplier and then reviewed by our clinical safety team with our services. So big pieces of work that the supplier needs to do, and we need to facilitate with the services that we work with. So in this case, this particular service that was using the AI tool. And then a data protection impact assessment, which is a DPIA. This is a legislative requirement, needs to be completed or needs to be updated if it's been completed. It hasn't been completed for a while. So that was our baseline, 3 big pieces there. And what we also did was we reviewed the evidence of this tool, and we wrote a report whilst working with the following expert groups. So we worked with our supplier, service manager, digital procurement, research and development, our wider digital directorate, commercial, and then our project management office. So these were huge stakeholder groups, that we worked with in a short space of time. I think it's important to clarify and highlight that we aren't responsible for bringing technology into the trust. We don't make that decision. That is for the service to make that decision, commercial to make, whoever makes that decision, they can. We are here to ensure that it's meeting assurance standards. So we don't have any bias. We don't have any particular preference. We just want to make sure it's meeting those standards. If it doesn't, they need to ensure that they do meet it through these various forms. And if technology doesn't meet our criteria and our standards, then we will say that it shouldn't be procured. We would advise. So I think that's really, really important to highlight here. So this is one case study that we worked on fairly recently. Another case study is actually talking a bit about AI, which is obviously, as I've mentioned, quite an interesting topic at the moment. So the rising public interest in usage of AI has led to these many questions around its safety, capabilities, and the impact it will have on the workforce and actually wider society. So what we did is we noticed that there was this interest not only nationally, but also within our own trust. And we developed an AI guidance document for trust staff. And to our knowledge, this is the first in the NHS. And this builds on existing policies that we have within our organisation, but also some of the NHS work that's already been published in order to promote responsible innovation. And complementary to this, we held an AI and the NHS workforce roundtable discussion with national experts and interested stakeholders, and their aim was to foster a discussion as well as creating this direction and influence in this space. I've got a couple of snapshots here of the pieces of work. Obviously, I haven't got the report here because of confidentiality purposes at the moment. But the guidance for the ethical use of AI, it was really about making sure that AI was in the most simplistic and clear language possible. We wanted to educate our staff on what AI is, what are the principles of AI, what types of AI there is that can be used, and actually what to do if staff want to use it within the trust. What we want to make sure is that there isn't any unethical use of AI. People aren't using AI for reasons that they shouldn't be. We hadn't been alerted to anything at the time, but we just wanted to make sure we are staying ahead of the curve and actually educating our workforce. So it was a very short briefing paper, and it was published on our trust website. And in order to gain some traction, it was presented to our executive board and our transformation board as well. And it might be updated as the kind of legislation or the policy papers might, because this is such a fast-paced area. As things publish and change, we will update our guidance. But that is something that we decided to take the initiative and create. And then the AI and the NHS workforce roundtable discussion. This was an opportunity to gather some key stakeholders, as I've just said, together to talk about how AI can transform the workforce in the NHS. And we wrote a report, and these were our follow-up sort of conversations that I can share with you, that the report can be used as a benchmark model for regional ethic review boards who can play a role in supporting the outcomes. There are further aspects to consider, such as the notion of getting informed consent from people before you allow their IP or image, voice, or text to be processed, depending on the type of data being processed. The environmental impacts of AI systems, this is quite key, talking about green sustainability technology, which is actually quite timely at the moment. And then the special area of AI and mental health, such as technology assessment and monitoring, evaluation, and or evaluation of impact. And we're planning to have a few more roundtable discussions at the moment in a number of locations. So that's the pieces of AI work that we have done and continue to do. So 2 different case studies there that hopefully illustrate and bring to life the work that we do in our trust. Some next steps. So this is some of the next steps that I've come up with, but very much thinking about how, as we are at the forefront of digital ethics in the NHS, first of all, thinking about how we can develop a digital ethics policy and strategy within the trust. That's the first thing, and how we can develop stronger collaborations with our stakeholders. Thinking about working more closely together with our service users as well, our service user groups, and thinking about our change management and education to foster empowerment in our workforce, and working more closely with our regional and national partners to share our learnings. Those are my next steps, really, hopefully the next sort of few months or to a year when it comes to digital ethics. So that is it from me. Thank you so much for listening. I'm happy to take any questions. I'll stop sharing my slides.
Thank you, Farah. Really interesting. So just as a quick reminder, if you've got questions for Farah, if you can type them into the Q&A box, and then I will ask them on your behalf. If somebody else has already typed a question in there that you are interested in, you can upvote it so that it'll rise to the top as we get the questions coming through. So yeah, hopefully that's fairly self-explanatory. The first one, so really goes back to your second case study, and I'd made a little note of a question myself, but in fact Mary has asked it far more eloquently than I could. I'm just saying that AI seems to include everything from analytics, pattern recognition, machine learning to generative and hallucinating AI. I'm not sure about hallucinating AI. But the real crux of the question is, can ethics, a human concept that's alien to machines, be reliably applied? What do you think?
I'm biased, I have to say. Good question. I'm biased. I think yes, I think it can be. And I think it's it isn't that difficult, I think, to embed ethics to AI. I think AI, in my opinion, has become very big and almost intimidating as well to people. And I don't think it is actually as intimidating as it sounds like it is. I think we don't need to know the machine learning in order to understand AI. I think what we do have is lots of experts and researchers and professionals working on ethics. It's about asking the right questions when we embed AI into our day-to-day life. And I think as we use AI, I think we are going to become much more understanding of how to use it, how to understand when not to use it, and understand when we're dealing with bad tech. I think we think about the transformation of technology in our lifetimes. The questions that people are asking about AI now, people probably asked about the internet, the World Wide Web, and other technologies. And I think, you know, looking back, we can see there's a fear of change, but actually this change is a positive change. And I do think that we can actually take a human concept of ethical thinking and actually not change the technology per se, but actually ask the right questions before we use it. And I think it's becoming quite robust because we have so many experts that are working on the development of AI, are dedicated to this area, very dedicated. And we've got departments all over the world, like we've got, you know, University of Oxford has their own ethics and AI center. We've got Harvard University that also has the same, I believe. So we've got real experts working on this area. So I'm fairly confident. It's about making, for me, it's about making sure that we're educating the wider public and making sure that they know how to use AI. But we're using AI already. We're using generative AI already. There are some things we're already using that people might not call AI, but it is already AI. It's just such a broad term, and it can be quite overwhelming, I think, because there's so many different types of AI you just listed. So, but I do think we can embed a human concept of AI to human concept of ethics to AI.
And I suppose in terms of AI, for me, one of the challenges there is whether it's decision making or decision support, i.e. so decision support, there's a recommendation of something and a human expert then takes the recommendation and then does the ultimate decision. And I guess particularly in a clinical context, the magnitude, the importance of the decisions can escalate hugely. So I suppose it's just interesting your thoughts about how do you get that balance right between automated decision making, where it might be something that's relatively trivial and that's acceptable, through to something where the clinical outcomes could be quite serious if you get it wrong, and actually you want to make sure that's decision support rather than decision making. Any thoughts on that, Farah?
Yeah, and it goes back to the first case study that I outlined, and obviously I kept lots of details confidential. But the supplier who created this AI self-referral tool, I think we're a mental health trust. This is a tool that targets those service users with mental health difficulties or conditions, and their self-referral tool is a tool that's designed to actually kind of gather some questions and answers from potential service users and actually escalate if there are warning signs, and escalate to the right sort of clinical team, for example. And so it is actually a lot of decision making within that tool, but then the sort of outcome is actually assessed by the clinical team. So this AI tool does the decision making, part of the decision making, but there are also clinicians on the other side that see that decision making process. So this supplier had done a lot of research and, of course, done an evaluation, had worked closely with service users, clinicians, to make sure that the tool was working in the way that it was supposed to be working before it was actually implemented. So it is a real challenge, and I think that it is about that collaborative working with the right stakeholders to make sure that it is being used effectively within healthcare. And this AI tool is not the only one. There are many other types of innovators that are using AI tools to improve diagnostics, for example, is one way. And of course, these things can be quite critical. If you misdiagnose somebody, you know, that can lead to serious outcomes. So there are lots of different types of ways, but it is a careful kind of combination of that kind of working together with the right stakeholders.
Yeah, and so I guess also we're talking about medical practice there, ethics is always a key part of that, whether it's technology enabled or not. And so how do you actually make sure that you get medical practitioners properly aware and thinking about digital ethics?
So I think and this is a big part of the NHS workforce, digital and data and technology workforce plan there's been many reports and reviews that have been done, but the NHS wants to train up their workforce to make sure they're digitally capable. So, and they have those tools to actually utilize digital technology, but understand again those things like digital ethics and think about digital transformation. So I think there is this workforce plan that is underway, and back to my introduction about me being on the Digital Health Leadership Programme, it's actually a flagship NHS England programme for future digital health leaders, current digital health leaders, to broaden their leadership skills, and it's incredibly successful. And we see, we do see a mixture of clinicians and non-clinicians, but that speaks to I think, the interest that lots of people within the workforce have to actually be more engaged with digital transformation and subsequently digital ethics. For example, digital ethics, there's already an interest there and it's already happening, but sometimes it's not named as digital ethics. And I think that's one of the things we try and do is kind of compartmentalize it into this particular area, and that's what we're trying to do is make it kind of a particular type of sort of framework as such, so that it can be named as digital ethics. But I think it's very much a national strategy and workforce plan, but each trust needs to engage with their workforce to assess their digital literacy skills, and that work is depending on the trust, depending on the area of the country you're in, it can be wildly different. So I was actually working with some of my colleagues on digital literacy last week, and in relation to the workforce. So it's quite a broad area, but it's something that many of us in the digital health space are really quite passionate about. I hope that answered your question.
I think it does, yes. I think it leads on to something else that I'd noted down, was the fact that you mentioned at the start that you're the only ethics team in the NHS, and you mentioned there about this needs to go nationwide.
Yeah.
So what were the particular drivers that meant that Surrey and Borders set up a team, whereas others, if they haven't got a team, then hopefully they've got an individual who's covering it? So was there something happened in the past that meant they took a view of we don't want that to happen again, or maybe somebody was more forward thinking? What's your thought of the origins there?
Yes, I joined the team after the team was established, I have to say, but our directorate is very big, and we have estimated 200 people in our digital directorate, which is quite unheard of, actually. And Surrey and Borders has always been at the forefront of digital transformation and innovation. So it was a decision that was made by the senior leadership team within the directorate, that there was this kind of gap that couldn't quite be filled by maybe quality assurance, which is usually sits within the nursing directorate in many trusts. It wasn't really, there was a gap there when it came to digital and ethical practice, and that was the subsequent kind of reflection there on creating this, creating first of all the chief digital ethics and assurance roles, and then subsequently my role was very much about how do we take our ethical thinking into our transformation program. So I think it's very much a reflection of how innovative our directorate is, and forward thinking it is.
Yeah, that's good. So just going back a little bit so Mary asked the previous question about AI, and just come up with a follow-on one, which I'm going to have to read because I'm not a medical professional, but
I hope I can answer it.
Well, we'll see how we go anyway. So she pointed out that the AI was trained on plural effusions and learned that drain equals effusion. So I think that suggests it's an incorrect assumption of linking the two words. So how are tools retrained when they're biased or disproved? How do you actually either spot or correct that if the behavior of the AI isn't quite correct? How do you actually, what are the good practice approaches to try and make sure you've spotting it and correcting it?
I guess I'm not a back-end AI expert, I have to say, as you can probably judge. But my understanding of AI is the more data you feed into a particular AI tool, the more accurate the sort of outcomes might be. So it comes down to those back-end developers, along with those machine learning experts, actually ensuring that the AI tool is actually being utilized with as much data as possible, so it is as accurate as it can be, and that there needs to be thorough evidence base with a tool before it actually is used. And I think when it comes to evidence generation and digital technology, it can be quite poor, actually, and which is quite disappointing to say, especially when it comes to healthcare. We want to make sure that when we're using a digital health tool, that it has a solid evidence base. But how do we support suppliers in making sure that they are not wasting years and times of doing trials that take lots and lots of time to publish, that they're actually getting a really good evidence base in a good amount of time, and actually then it can back up their sort of what they're saying the tool can do, and it can actually then be implemented into an organization. So hopefully that answers your question.
I think so. I think it also,
Mary, fingers crossed.
Thinking aloud almost on it is, it's almost like a procurement question. If you're selecting a tool provider, whether it's AI or any other kind of decision support tool, maybe a key question to ask is, how do we raise concerns that the outputs aren't correct and we get them updated or corrected? So if there's an organization who hasn't got that kind of process, I would potentially have concerns about using them. If they're a bit more mature, you'd hope they've got a fairly slick process that can be used to feed back and get the tool working better.
But I think it's what's great about AI is that there are so many organizations that are doing great work. I think like, for example, the Turing Institute, they have dedicated AI ethics professionals and fellows working, and lots of their events are actually free. So anybody who's interested in just finding out more about AI, I would encourage you to go out there and attend some of these events, because they've been very informative for my colleagues and I. And it's not just the Turing Institute, there are many other organizations as well. The ODI is another.
Yeah. That's good. So Carl's asked a question, and it's again, it kind of mixes up with one that I prepared as well. So, so what approaches do you take to ensure usability and accessibility of digital applications, promotion of improved health outcomes for healthcare users, but in particular users who are challenged in areas such as hearing, sight, or about who struggle with digital use of technology? You mentioned earlier about people who've got mental health problems. So it's, how do we actually make sure that we're thinking about the end user and don't assume a typical user who's IT literate, they're in their 20s, they can do they can smartphones, Facebook, TikTok, whatever. Not everybody fits in that bracket. So how do we actually get the balance right there?
I think, first of all, and you're right, especially when you're working with a healthcare population, a diverse population, there can be lots and lots of conditions that people have. And with our staff as well, we've got a diverse staff workforce. Not everybody's as digitally literate as other people. And as I said, I was in a meeting last week with some of my colleagues talking about digital literacy. And I think it's, first of all, it goes back to the supplier. The digital innovators need to be taking accessibility, usability seriously. These aren't buzzwords. These are actually really, really important. And these are huge gaps if they're creating a tool that hasn't been, that can't be used by the population as a whole. So it really comes back to, first of all, them doing what they're hopefully supposed to be doing. But for us, our job is, and I think that's what's great about the DTAC, is that it has that accessibility and usability aspect to the form. So we can begin to see if there are some challenges in that area and how we can improve those challenges, how we can improve those areas, and working with our service user groups that, you know, again, these things can sometimes be seen as buzzwords: co-design, public and patient involvement. They're really working with service users as equal partners in this journey is actually very, very important. It's something we want to do more and more of. So working with our service user groups who can actually help to identify some of the issues within a technology, for example, actually can really, really help. And if, let's just say, we do our assessment, we work with our service user group, nothing seems to get picked up, something gets procured, but then working with our clinical staff who will then identify that maybe a technology isn't quite useful for this particular group, for example, that particular group, I think then we can also help to resolve some of the issues there, although that's not ideal. So it's about focusing on accessibility and usability every single step of the way. And we can always be better at it. I think there are more and more types of frameworks and forms and assessments that are being published now where you can assess people's digital exclusion in a population, for example. So it's about how do we make sure it's not laborious? And that's the challenge. We don't want to burden clinical staff who already have enough to deal with. How do we make sure it's not laborious, but how do we make sure we're assessing at each step of the way and making sure we're not excluding particular population who might have particular needs.
Yeah.
And there are technologies that are developed for people with particular conditions. So we have that already in our trust, where we've got particular communities that use particular products, especially designed for them. So we support that procurement process. So hopefully not trying to exclude anybody, but it's very much making sure we are focused on accessibility and inclusion every step of the way of the process.
Yeah, that's good. So yeah, there's also Mary's come back with a bit more, and Carl's also come back, and it's back on this old AI one again. So
it's very popular.
We might get off AI eventually, but
yeah.
So I think it's interesting. I mean, Carl's point was about model bias, whether it's intended or unintended, and how you deal with bias in models. Mary's point was about sort of dealing with poor quality data, and anybody who knows me and has listened to my webinars knows that, yeah, data quality is a key topic of mine. So again, it's about how do we make sure the AI has got the right inputs, the right processing, the right outputs, and the actions that are taken as a result of those outputs lead to the right outcomes.
Yeah, and I think for us, and it's not a cop-out answer, I promise you, but we don't want to get too involved in the input-output of AI, because that's not our job. It is the supplier's duty, and then they have to present to us their evidence base. They need to show the trust, how their tool works, what the evidence base is behind it, and we can then assess the evidence base. And I'm fortunate that I've got that academic background, and so I have that research background. I've got that data analysis background, so I'm very fortunate I can sort of assess these sort of data sets and kind of understand how robust these data sets are, or the evidence bases. And we have been in that situation where an evidence base has been presented to us for a particular tool, and we're not quite convinced. And then we do pull in some of our other colleagues, for example, to come in and actually assess that. And then we can then make arrangements how we can improve that. For example, do we do a service evaluation to get a bit more data before we allow that procurement to go ahead? But I don't think anything is truly unbiased. I think we'd like to live in a world where everything is not biased. That's not true. We're biased as human beings, and we create the tools. I think it's about acknowledging that bias, being honest about it, and actually presenting that forward, and being honest in the data set, so that we're aware when we're procuring that product of what the limitations of that product is. So it's about that honesty, I think.
But also, I mean, it's interesting, you've mentioned procurement there quite a few times, doing a lot of evaluation of the supplier, the tool, the processes, etc. And one thing that strikes me is that we also need to be quite careful of the end users. Don't just assume that, oh, the tool has passed all far as
absolutely.
So it must be perfect, and they trust it implicitly when they might be moving into different areas where the tool hasn't been tested. So I think there's a behavioral issue there about users remaining skeptical of the outputs, of seeing it's a help, but maybe still having that level of skepticism. How do we encourage that and make sure they don't just fall back on, oh, computer says yes or no or whatever?
Yeah. Are we talking about the service users or the clinicians? Because we want to make sure the clinicians know the tool that they're using. And, when we're in an NHS where we've got lots of staff that what we call agency staff. They may not know, that they may come on the ward and they may be told this is something that we use, and that's their first time. We need to make sure that they are getting the adequate training, supervision to use a particular tool, for example. So, but yes, you're absolutely right, and I think that's why we come in and we don't end at procurement and step back. We actually do reviews consistently so that we're picking up any issues along the way, and that we can step in and resolve those issues, rather than sitting back and actually then only being brought in when something's gone wrong. So it is very, very sensitive and quite careful on how we deal with this.
I think my question was very much more aimed at the clinician users who, you mentioned agency staff who might be less trained, less familiar with the tool, but also thinking about what can happen in healthcare settings where things are very pressured, people are working against time, against backlogs, targets, that pressure to be quick means that they maybe don't take that extra 5 or 10 seconds to properly think something through, rather than leaping straight to it. And so I guess that, again, that's the area I was trying to tease out.
And we're very lucky that in our directorate we've got teams that actually work with clinical staff. We've got like a learning and adoption team, we've got a health tech team that actually work on the ground with our clinicians. So they're actually almost experts in the technology themselves. They talk to the suppliers, and actually then they train the clinical staff, and they really do identify what issues there might be, and they bring that then back to us. So we're very fortunate. I think a lot of trusts don't have the structure that we have. They are really just implementing something and with very minimal staff to support in digital, and then clinical staff are left to implement it and use it with service users. I think we're unbiased, but we are a good example of an organization that has some of the resources to do that work.
So I guess for other organisations, they need to just not forget the risk element of it and make sure there's appropriate risk assessments have been covered.
Yeah, and I think in my previous role, I used to actually work with innovators. So and so it's really interesting being on the other side of it. It is the innovator's responsibility. They need to understand, and they do understand, that the NHS is very pressurised. They need to be helping the clinical staff and the organisation to understand the tool, train them on the tool, and implement the tool. It is their responsibility too. It's not just, you procured my tool, bye-bye. Like, they need to help along the journey, because something that puts more pressure on the clinical staff isn't, even if it's a great tool and it's going to solve out, improve outcomes and everything, if it's going to take up clinical time, it's not actually, that's money, it's not really effective. So we don't want to go down that road, and I can imagine it does happen. So it is very much a joint working relationship with our supplier as well.
Sure, yeah. So just final question now, because we're sort of running out of time. I think it'd be an interesting one there, and this is a question Robert posed a little while ago now, so we've got around to it eventually, Robert. Really summarising is, what are the presentation tonight was based on a healthcare setting. What are the key factors that might apply in other settings, other organisations, other industrial organisational contexts? Are there any takeaways in terms of that people who might not be working in healthcare can use when considering ethics?
Yes, and I think most of the digital ethical work hasn't been done within the NHS. We took the definition and the elements of digital ethics and actually kind of transformed it into our organisation. But those underpinnings that I spoke about earlier on, about privacy, safety, security, accessibility, care, trustworthiness, those aren't, again, just buzzwords. Those are key components of how we should be educating ourselves, our colleagues, and empowering citizens overall. So I would definitely, going back to those sorts of elements, I think are really, really key, and how you can embed them within your own organisation and within your own work. Yeah.
Okay, that's good. Thank you. So that's actually a good prompt there when the recording's out, to actually go back and review.
No problem.
Review the wise words of Farah. So yes, just a quick reminder that the recording will be available on the BCS member group's YouTube channel. It's probably a couple of weeks away before they finish doing the processing. But I'd just like to, on behalf of everybody, thank Farah for a really interesting presentation and engaging conversation.
Thank you.
And thank you all for attending, and thank you, Farah, much appreciated.
Thank you very much.